Thank you for coming today to listen to Dr. Khoury and my own presentation on the growing challenge of major trauma in the older adults, a role for the geriatric assessment. We have no conflicts or any disclosures today. So the objectives today are to review the present and future geriatric trauma demographics, to describe the unique and challenging complexity of managing trauma in the older adults, and to outline the benefit of a collaborative geriatric trauma model in caring for older adults at the Ottawa Hospital. So we begin to review present and future geriatric trauma demographics. So why is geriatric trauma such a hot topic today? It's because people 65 years of age and older are the fastest growing demographic. They are living longer, more active lives due to medical advancement, but the comorbid diseases associated with aging puts them at risk for injuries and hospitalizations related to their injuries. To provide you with a better understanding of the growth in this age group, in 1921, the 65 and older population made up only 5% of the Canadian population. In 2014, it rose to 15%, and it's predicted by 2030 that they will make up 23% of all Canadians. But more importantly, the greatest growth will be seen in the 85 and older. They are expected to rise from 2% of all Canadians to 5%. This is significant as they tend to have more comorbid diseases and increased frailty, putting them at risk for injury and hospitalizations related to injuries. With this increasing population, we have already seen an increase in the number of trauma admissions. In 2004, 15% of all trauma hospitalizations were 65 and older. In 2014, the numbers rose to 28%, and it's estimated that by 2050, that 39% of all trauma admissions will be 65 and older. We're now going to describe the unique and challenging complexity of managing trauma in the older adults. So the leading cause of trauma in this age group is falls. 80% of all trauma is related to falls in the older adult. Falls are a major cause of disability and death. They're the leading cause of injury related to hospitalization among Canadian older adults. It has only been in the last 10 to 15 years that the literature has started to address the challenges associated with managing these complex older adults, as the existing trauma protocols and research has focused on the younger trauma patient. What we've discovered is that these people tend to have worse outcomes compared to the younger patients with similar injuries, that they're having higher mortality, higher complication rates, adverse discharge outcomes, and longer hospital stays. They have increased vulnerability as a function of the effects of advanced age, comorbidities, and frailty. What they've also found is that the lower mechanisms of injury account for a larger percentage of deaths secondary to trauma. They are under-triaged as their baseline frailty is underappreciated. This is leading to underdiagnosis, delays in recognition of injuries, and delays in recognition of geriatric syndromes. The current trauma systems were not developed to treat older adults. Historically, these patients are under triage with delays in transfer to trauma centers compared to the younger patients. Under triaging increases for patients 65 and older and reaches up to 60% for those patients older than 90 years. It's argued that the trauma centers are designed to treat the younger patients and may be inadequate in their treatment of the older trauma patients. Delays in recognizing the special needs of the older trauma patients may result in suboptimal care. What we do know is that the older adult trauma patients have increased death rates at 51%. They have increased length of stays, with the average length of stay being 18 days compared to the younger population at 13.5. and falls contribute to 74 to 80% of all major injury hospitalizations. It was in 2012 that the American College of Surgeons, recognizing that the current trauma systems did not address the unique needs of this population, and they developed the Trauma Quality Improvement Program. The goal of this program was, the aim of this program was to employ better risks assessments, to ensure adherence to key strategies for this population, to ensure prompt recognition and treatment of the complications, with the goal of decreasing the mortality and morbidity. What they developed was an adult-specific care protocols within a multidisciplinary team, and they recommended that early geriatric involvement and a comprehensive geriatric assessment be performed on all trauma patients 65 and older. I'm now going to pass over to Dr. Khoury.
Thank you, and happy to be here today. So we all recognize that the challenges in providing healthcare for older adults are quite significant, and these challenges are even greater in older adults with trauma. And this is why I believe that these patients require a multidisciplinary approach that encompasses appropriate and careful consideration of the changes in physiologic, psychosocial, and functional status. So this is where the CGA comes in, or the Comprehensive Geriatric Assessment. And we define the Comprehensive Geriatric Assessment as follows. It is a multidimensional, interdisciplinary diagnostic process that helps to determine the medical, psychological, and functional capabilities of a frail older person in order to develop a coordinated and integrated plan for treatment and long-term follow-up. So the CGA is something that geriatricians or geriatric healthcare providers almost use on a daily basis. It is our most important tool when we're looking after our patients. How does this apply to the geriatric trauma population? So we're all now familiar with the hand that represents the 5 M's. So the 5 M's were helped to be developed by our very own Dr. Molnar and Dr. Alan Wong. The 5 M's are described there. So how do we use them when we're seeing geriatric trauma patients? So when we're looking at a patient, we want to make sure that their cognition is assessed very carefully. We do use the CAM tool. The CAM tool is the confusion assessment method. We want to make sure that the patient is not CAM positive, or if they are CAM negative to begin with, we want to make sure that they're not now becoming CAM positive. At times it is difficult to appreciate when a cognitive status of a patient changes, and they can become delirious without the care providers noticing. And as a geriatrician, I also know that sometimes delirium can be an atypical presentation of an underlying medical condition. And we need to do a proper workup when somebody becomes delirious. Mobility obviously is extremely important. We want to mobilize the geriatric patient, trauma patient as early as possible. And geriatrics team can help to look at gait and balance. We make sure that we're helping to prevent future injuries and falls. Medications. Given the comorbidities that accompany advancing age, polypharmacy is a significant concern in the management of these patients, owing to the increased potential for adverse drug reactions and drug-drug interactions. But really of particular interest in trauma is the subset of population on chronic anticoagulation, because in the setting of trauma, there would be a significant increased risk of bleeding. We often monitor their level of consciousness and their cognition very carefully, and if there's any change, even if they initially did not present with any bleeding, they can afterwards develop bleeding in their brain or in an area that's close to where they've suffered the trauma. Multi-complexity, geriatric healthcare providers are obviously the experts in managing multiple comorbidities. And finally, what matters most to the patient, So we are very adept at having goals of care conversations. We also always want to make sure that any treatment plan that's recommended is in keeping with the individual's own meaningful health outcome goals and care preferences. So have there been studies showing that there are benefits to CJA? And so there are many studies that have looked at this, and they were able to show that vulnerable older adults benefit from interdisciplinary inpatient care. Those studies, however, have been predominantly done in orthopedics, and they showed improved clinical outcomes and return of function, as well as decreased mortality at lower costs compared to usual care. There are also studies that looked at orthogeriatric units for hip fracture patients, and they focused on improving mobility and standardized pain regimens, and they were able to demonstrate a reduced 6-month mortality rate as well as morbidity. Summarized here the benefits of CGA in orthopedic patients. So there's usually around an 18% reduction in delirium after hip fracture. So those who undergo CGA, or comprehensive geriatric assessment, the delirium is reduced from 50% to 32%. There is a decrease in length of stay, and there is a decrease in complication rates. So they're less likely to develop pneumonia, delirium, pressure sores, catheter use, and pain. And what about in a geriatric trauma population? Unfortunately, there haven't been many studies looking at the role of geriatric care in this population. There were some studies that looked at dedicated geriatric trauma units, and they did find that these were associated with decreased mortality, complications, and reduced length of stay. Other studies looked at when they trigger geriatric consults. This was associated with reduced delirium, hospital mortality, readmission rate, length of stay, and discharge to long-term care facilities. Other studies looked at geriatric-directed interdisciplinary care, and were able to show significant decreases in delirium and 30-day readmission over geriatric consultation alone. Some studies looked at implementation of geriatric-specific practice management guidelines and showed that, which included geriatric consultation, and they did show decreased mortality. However, other studies did not show any improvement in outcomes when they implemented a mandatory geriatric trauma consultation. And of note, there are no randomized controlled trials that exist for proactive geriatric trauma consultation service. So this brings me to our last objectives, which is really to outline the benefit of a collaborative geriatric trauma model in caring for older adults at the Ottawa Hospital. So we know that CGAs do help improve outcomes, and we wanted to look at whether implementing a comprehensive geriatric assessment model at the Ottawa Hospital on the trauma unit would help improve outcomes of these patients. So in 2017, in collaboration with the trauma team at the Ottawa Hospital, we decided to implement a proactive geriatric medicine consultation service. And really, the aim of this project was to establish partnerships and build capacity for age-appropriate care through early initiation of a comprehensive geriatric assessment to identify and manage frailty, cognitive impairment, mobility concerns, high-risk medications, and multimorbidity. We did have additional goals. We wanted to look at the characteristics of the older adults who sustained major traumatic injury. We also wanted to provide patient, family, and team education. And finally, we wanted to explore the feasibility of an integrated geriatric trauma process. So in collaboration with trauma, we decided to start enrolling patients in November of 2017. And the study actually went on for a year initially, and we wanted to have some criteria. And these are the inclusion criteria were really all patients over the age of 75 who were admitted to trauma services. And the patients were initially seen by our geriatric nurse specialist or a geriatric physio specialist on the consult team here at the Civic campus. And if it was felt that the MD involvement was needed, then the MD went to assess the patient. And the only exclusion criteria was that we didn't see patients who were admitted to ICU. So basically, most of the patients who were admitted over 75 were seen by our team. So we wanted our comprehensive geriatric assessment model to be proactive. So we wanted the case finding to be done systematically based on predefined criteria and processes. We wanted to make sure that our team was involved early, before treatment decisions were made. And we wanted to focus really on prevention of geriatric syndromes. And finally, we wanted to ensure that our recommendations were implemented directly. It was really important that we provide education to the nursing staff. Nursing interventions are extremely important in ensuring the success of this intervention. Our team members here at the Civic, our assessors, were incredibly amazing at providing education to the trauma nurses. We wanted to make sure that they were aware of the importance of providing adequate fluids and nutrition. We wanted to make sure that they were treating pain on a regular schedule. We wanted to make sure that they were mobilizing the patients early. Even if the patient was delirious, it's really important that we get them up, sitting up in a chair, and eating their meals while sitting as opposed to lying in bed. We wanted to make sure that they were giving the medications regularly and adjusting new medications as appropriate. Removing all necessary tubes, so Foley catheters, even if it's convenient to have a Foley catheter in place, it's important to remove it as early as possible in order to prevent infections. We wanted to avoid restraints. Physical or chemical restraints are used sometimes not infrequently, and it's important to educate nurses on how to use alternative ways of reducing restlessness or agitation in patients. Regular toileting is very important to provide, to ensure that we avoid incontinence. Offering eyeglasses and hearing aids. So people who wear glasses or hearing aids, we ask families to bring them in. It's extremely important in preventing delirium, or if they're already delirious, to help reduce their anxiety and agitation. Providing frequent orientation is extremely important. And finally, we encourage families to be present as much as possible. So during the 1 year, initial year that we looked at these patients, we actually assessed 87, we identified actually 87 geriatric trauma patients who fit our criteria. Of the 87 patients, 75 were followed by the geriatric medicine consultation team, and we provided recommendations that were followed by the trauma service. 56 of these patients were followed regularly by our team, but were not transferred to the geriatric medicine unit. But 19 patients were transferred to our units because we felt that they would benefit from more focused geriatric assessment and intervention. So in the early days of our study, we were actually able to show very clear early benefits. We were able to show that we improved geriatric collaboration with the trauma team. The trauma team, I have to say, they're incredibly open and to our suggestions. they really appreciated our presence, and they actually expected to see us there. We were there almost daily, and they would wait for us or look for us when we were on the unit, because they had really great questions and they really wanted to learn in order to help their patients. We did show that we were able to identify early on delirium and begin managing it. We looked at polypharmacy earlier than we would that the team would otherwise look at polypharmacy, and we looked at contributing medical concerns. And one of the things that I have to say is some of these patients, when they would come in, the medication reconciliation at times would not be done for 3 or 4 days. And our involvement was really essential in ensuring that the patients that we figured out what medications they were taking at home, and we made sure that they were being given these medications in hospital. I remember one case of a patient who was on a very large dose of opioids as well as benzodiazepines, and that patient was extremely delirious and agitated, and nobody could figure out why that was. And our team was able to find a list of medications that they were taking at home, and were able to reinstate those medications in hospital and help reduce the delirium and agitation. We're able to show that there is obviously an increased number of patients seen by our team. More patients were being transferred to the geriatric medicine unit, and on discharge, there were more patients referred to specialized geriatric services. And finally, there was an increase in supporting the trauma team for goals of care discussion. It's important to recognize sometimes that patients are not going to do well, and rather than wait 1 or 2 or 3 weeks, maybe begin having that conversation early on in order to reduce suffering in patients. So as Joy mentioned earlier, most of the patients who present with older patients who present with trauma, the mechanism of injury is mostly related to falls. So in this population that we studied, we actually looked at why they came into hospital, and 86% of these older patients came in because of a fall. 12% they were due to a motor vehicle collision, and 2% only came in with trauma related to a penetrating injury. And I mentioned earlier that, some patients are on anticoagulation, and so when they come in and they suffer, the x-ray on the left shows a rib fracture, and this is actually, one rib fracture, but a lot of the patients we were seeing, they had not only one, but at times 3 and 4 and 5 rib fractures, and some of them were displaced and very painful. And there's also a lot of bleeding and hemothorax that's present, even in the absence of anticoagulation use at home. And the CAT scan on the right there shows a bleed. So the white part that we see is blood. And sometimes if the patient says that they didn't hit their head, a CT head is not always done. So sometimes we have to go in and really advocate for a CT scan to be done in order to rule out an intracranial bleed. And sometimes the bleeds are quite large and they start to push on the adjacent structures, and patients can end up with very poor outcomes when that happens. So what about the trauma patient demographics, so the people that we saw on the trauma unit? So I know this is a very busy table, but I wanted to show a few basic demographics there of the patients that we saw. So the mean age of the patients was 85, and the frailty score, the average frailty score was around 4. So not really too bad. The mechanism of injury, as I mentioned earlier, so most of them, 86% of all patients presented with a fall that caused their injury. Mean number of comorbidities was around 7. Home medications, on average, they were taking 9 medications at home. And some of them had a history of osteoporosis. 40% of the patients had suffered falls in the year prior to them presenting to hospital. So if we had seen these patients earlier, perhaps we could have prevented a fall which led to this hospitalization. 46% of them used a gait aid in the past year, and 42% had some kind of cognitive impairment. The patients we followed on the consult team, so similar demographics. So we did follow patients who mostly, frequently presented with falls, but also patients who had suffered falls in previous years and who did suffer from cognitive impairment. So very similar demographics. So those we continued to follow had similar demographics. And finally, those who came to the geriatric medicine unit, the reason why they ended up coming to our unit is because we felt that they needed a more intense geriatrics involvement. And we also felt that they needed that extra bit of special care, and that we felt also that an additional stay on our unit might help improve their functional status and level of independence before leaving the hospital. I wanted to point out that more patients that came to JMU were cognitively impaired, so 52% versus the 41% in the general group. And also here wanted to show that osteoporosis treatment, we did actually end up treating patients for osteoporosis, but we only increased the percentage from 27 to 31%. So there's some work to be done there. I'm not sure why some of these patients didn't start treatment for osteoporosis, but perhaps we decided that we would see these patients in follow-up in our outpatient clinic and start osteoporosis treatment then. And I also like to point out that the patients who came to us tended to have more comorbidities than the patients who did not come to our unit. We also wanted to look at whether we were able to improve outcomes in these patients. So looking at the patients here, so when we looked at all patients, so whether they came to our unit or not, we looked at their length of stay. We looked at whether they were able to go home or if they had to go to convalescence or rehab, and whether they had to go to retirement home or long-term care. And some of them actually were repatriated. So the patients who were repatriated to their original hospital, we actually lost track of those patients, and it was quite difficult to figure out what happened to them afterwards. We looked at in-hospital mortality and number of medications on discharge, and whether they were started on osteoporosis management. And finally, we wanted to look at what their discharge diagnosis was. So I just want to show for the patients that we followed on the consult service, looking at delirium incidence, there's not a huge improvement. So 48% of these patients still suffered from delirium. So we didn't show any improvement or any difference in that. And we can discuss why that might be. Length of stay remained similar, so we did not help to reduce length of stay. In terms of discharge destination, same percentage, a very similar percentage of patients, in fact, less patients that we followed ended up going home. And I believe the reason that is because some of these patients, it was not appropriate for them to return home right away. We did not feel that they were necessarily ready, or maybe we felt that they needed a period of convalescence before returning home. Rehab, a similar percentage of patients ended up going to rehab. And in terms of in-hospital mortality, our involvement did not show reduction in in-hospital mortality. What about number of medications on discharge? In terms of number of medications on discharge, we did actually end up with higher number of medications if they were seen by our team. And I think it's usually because we started osteoporosis treatment. We did not start new medications. In fact, we did discontinue many medications, and but really we started patients on appropriate osteoporosis management. And finally, in terms of discharge diagnosis, as I mentioned earlier, a lot of patients come in due to the fall, and the discharge diagnosis, the most responsible diagnosis, was still the same, whether they were seen by us or not. And what about the patients who ended up on GMU? So was it really beneficial for patients to come to the geriatric medicine unit? So in terms of delirium incidence, we did not show a decrease in incidence of delirium. The length of stay increased, and that makes sense because now they're on our unit, and so they do end up spending more time in hospital, but really the increase was only 4 days. So it's not a really big increase. And I do believe the patients, by staying longer, that we actually do a really good job of ensuring that when they return home or when they leave the hospital, that there's a less risk of them returning with complications. In terms of discharge destination, we did actually end up sending more patients home than if they did not come to GMU. So maybe by staying there longer, we're successful in helping people return home. So 47% of patients went home versus 41%. We sent a lot of patients to convalescence, more patients. So it's a small number, but 15% versus 7. And rehab, we sent lots of patients to rehab. And we did send 16% of patients to retirement home. Again, I believe that when we make a recommendation for someone to go to a retirement home, it's because we feel that it's not safe for them to return home, and that it's actually beneficial for a patient to go to an environment where their care needs can be met, and that eventually helps to reduce the risk of them returning to hospital, and it decreases readmission rates. So we did not look at readmission rates, by the way, and that is something that we hope to be able to do in the future. If they came to the GMU unit, the geriatric medicine unit, they did go home on similar number of medications. But when we looked deeper into this, we were able to show that those medications, more of them were helpful medications like Tylenol and osteoporosis medications, and less inappropriate medications for older patients. In terms of osteoporosis management, so we did start 74% of patients who came to GMU ended up on osteoporosis treatment. And so that's really good. Why not 100%? Again, perhaps sometimes we wanted to make sure that they were doing well, and we were going to see them in follow-up in our clinic and start treatment then. And finally, I'd like to point out that for people who came to the geriatric medicine unit, their discharge diagnosis was changed, and instead of saying that they came with trauma-related injuries, we actually decided that their fall was the most responsible diagnosis. So a fall is the reason why they came into hospital, and all the injuries they suffered, they were complications of that resulted from that fall. Okay. So I just wanted to show this slide looks a little bit closer at discharge destinations. So if we look at the orange piece here, so all patients who, 45% of patients, a lot of patients went home, versus here very similar, so patients who were followed by the geriatric medicine consult team and the GMU patients. A similar percentage of patients went went home, 47%. I don't know where the numbers are here. They kind of disappeared on me. But in terms of rehab, I think we did send more patients to rehab and convalescence if they came to the geriatric medicine unit. Because again, we wanted to make sure those patients were safe to return home, and most of the time we felt that a period of convalescence or relocation to a retirement home was most beneficial for the patient. So just to summarize the key findings from our intervention. So as I mentioned, there's a high prevalence of reported falls in previous years. So many of those patients had suffered falls before their presentation to hospital. So is there a role for falls prevention? You all know that we have a falls prevention clinic here at the Ottawa Hospital, and the goal of this clinic is really to prevent patients from falling and suffering significant injuries. Because when they do end up in hospital on a trauma unit, their outcomes tend to be sometimes quite poor. The majority of patients were unable to return home directly from hospital. So not the majority, 47% went home, but really many of them had to go to convalescence or rehab, or maybe they needed to relocate to a retirement home. We did note that osteoporosis tended to be undertreated. So I think closer attention needs to be paid to the patients who don't come to the geriatric medicine unit. I'm surprised that the patients we followed on our consult service, I'm surprised that not more ended up going home with osteoporosis treatment. When they did come to the geriatric unit, they did actually, in fact, receive osteoporosis treatment on discharge. And the patients were being discharged on more medications than they were admitted on. And really that makes sense because they need to be on pain medications. Perhaps they suffered, they had an infection in hospital and they needed to be on antibiotics. Now they're on Tylenol, which they weren't on before. And of course, they're being treated for osteoporosis. So they need to be on their calcium and their vitamin D and their bisphosphonate. And as I mentioned, for the GMU patients, so the patients who came to us, they did tend to have lower frailty score, lower injury severity score. They did tend to have more comorbidities and more medications. And so I think the patients who came to us, they tended to be the patients who weren't as sick, the ones who hadn't come in with a really severe injury. And again, that makes sense because those are the patients we want to help return to independent living. There are the patients with more comorbidities, so perhaps more that needs to be done with them. And they are the patients who tended to be on more medications. Again, an opportunity for us to look at their medications and maybe start deprescribing or reducing some of the inappropriate medications that they may be taking. They also tended to have a higher incidence of falls in the previous year, as well as cognitive impairment. Their principal discharge diagnosis was more likely to be falls as opposed to trauma, and they were obviously more likely to be discharged on osteoporosis medications. So in conclusion, I hope you now realize that geriatric trauma is on the rise, and that geriatric trauma patients can be very complex, and a comprehensive geriatric assessment is essential in providing age-appropriate care. And finally, in our hospital here at TOH, we were able to show that a collaborative geriatric trauma model in caring for older adults has shown clear benefits. Thank you. And I want to say a special thank you to my co-presenter, Joy Morse, as well as Vicki Thompson. They were incredible in being the first ones to assess our patients on the geriatric unit. And also a special thank you to Shirley Wong, who couldn't be here today. She is also quite involved in our study. And the rest of this is the geriatric and the geriatric consult team and the BSO team. So everyone was really incredible and supportive with this project. And I just wanted to show also that not only do we like each other, like working with each other, but we also like each other enough to do things outside of work. we have fun.